This is Dr. Zepchinsky. This presentation covers Chapter 38, Common Abdominal Complaints in the Primary Care Text. These are the topics covered in this PowerPoint presentation. There are two exceptions. The first is the Rome criteria, which I address on the next slide. Rome criteria is used extensively in diagnosing and treating functional disorders of the GI tract, but it's not referred to specifically until later chapters. And the second is abdominal pain. There is a separate study guide for this, and it addresses abdominal pain at length. The Rome criteria was developed in 1990 by an international GI work group. The goal was to create a set of guidelines to help providers diagnose and treat functional disorders of the GI tract. Functional disorders of the GI tract are those that affect the actual function of the GI tract, such as constipation, nausea, diarrhea, vomiting, etc. The Rome 4 criteria is used extensively in diagnosing and managing functional GI disorders. In your text, it is specifically mentioned in later chapters, but there are references to it in this particular chapter. This text has a bit of general information describing abdominal pain. There is a separate study guide titled Overview of abdominal pain that reviews specifically the history and physical differentials in diagnostics. When considering each of the disorders that you're going to be studying, it's helpful to review the anatomy and the physiology of the GI tract. Keep in mind that how the patient presents to you is going to give you clues about which part of the GI tract is affected, and then that will lead you to the questions asked for the history, the parts of the GI tract to look at for the physical exam, and which differentials you'll be developing so that you can do diagnostics and then eventually reach a diagnosis and a treatment plan for your patient. Constipation, or difficult or infrequent defecation, is a common symptom in Western society. It is the most common GI disorder in the United States, particularly in older adults and sedentary individuals. We're also seeing a lot of constipation problems in younger children, like between 5 and 12, where they are having an NG tube placed and getting consistent go lightly until they start to move their bowels. The number one cause, is the lack of dietary fiber. Our daily requirements for fiber are about 30 grams. Most Americans take in about 10 grams per day. And think about the American diet. It's a lot of processed food, fast food, high in calories, fat, and very little fiber that makes the bowel work. There are categories for describing constipation according to the Rome 4 criteria. The first category is functional. That's usually related to low fiber, sedentary lifestyles and suppressing the urge to go. This happens a lot when people are in unfamiliar settings and they do not feel comfortable emptying their bowels. Disordered motility occurs in elders with slowed motility of the GI system. IBS, diverticular disease, gastroparesis, hypothyroidism, hypocalcium are also things that cause disordered motility. Secondary constipation is generally caused by medications. Opioids are probably number one, but also aluminum antacids such as Maalox, antidepressants, chronic laxative use, and there are some GI cancers that can cause constipation as well. This is an example of the Rome 4 criteria for functional constipation. These criteria have to be present for at least 8 weeks, and you can see them. 2 or more of the following: straining during defecation, lumpy or hard stools according to the Bristol stool scale, and I've included that in this PowerPoint presentation. The sensation of incomplete evacuation, not really emptying your bowels. Anorectal obstruction or blockage, that sensation that something in there is keeping the feces from moving out. The use of manual maneuvers to facilitate more than a quarter of the defecations. When I was a new nurse many years ago, I remember meeting an elderly woman who was absolutely obsessed with her constipation and requested a nail brush so that she could scrub the fecal material out from underneath her nails because she had been digging to try to get it to come out. This happens in people that are really affected by constipation. And of course, fewer than 3, this is just spontaneous bowel movements per week. Other is loose stools are rarely present without the use of laxatives, so we're not talking about IBS here, and insufficient criteria for irritable bowel syndrome. As a provider, you will begin each of your encounters by taking a history and performing a physical. You will develop the history of the present illness. You can use old cards or some other mnemonic. And knowing the Rome 4 criteria, you can start asking the questions you need to. The length of time is very important. The Rome criteria says 8 weeks. Here's a pearl for you. Get an operational definition from the patient. In other words, ask them, what are your normal habits? And what do you consider as constipation? You want to be on the same page when you're talking about their goals. What is the description of the stool? How does it look? Is it lumpy? Is it ribbon-like? Is it soft? Is it hard? And what are we doing for self-management? Are they taking some sort of a stool softener? Are they giving themselves laxatives or enemas? Then the next part is get a good list of their medications. There are many medications that cause constipation. Get a past medical history. Right there you can identify some areas that they may have problems, especially if they have already a diagnosis of IBS or they have diverticular disease. Get a past social history, alcohol, tobacco, social and family histories. Really want to find out if they are at risk for cancers. Then perform a good focused physical exam on the abdomen. You may have to do a digital rectal exam, especially if you're checking for sphincter tone, hemorrhoids, and anal fissures. This is a picture of the Bristol stool scale, and it is very helpful. You may want to take a picture of this and just have it on your phone, put it in your contacts under constipation, and you can look at it and you can show this to a patient, and they can tell you the type of stools they're having. This is a list of the common classes of medications that cause constipation. Notice the ones that are on here. There are antihypertensives, NSAIDs, opiates. Opiates are particularly implicated in constipation. Once you have completed the history and physical, make a list of possible differential diagnoses for this patient. What is causing the constipation? Look at the Rome criteria for functional constipation and see if that matches what you have found in your history and physical. And there is a terrific diagnostic reasoning algorithm for constipation in this chapter that I think would be worth your while to look at. Now we need to manage the problem. And what we're looking for here is symptomatic relief. It's very uncomfortable to be constipated. These are some commonly prescribed medication types, such as bulking agent, stool softeners, laxatives. Look at those and maybe make a list of those types that you can keep also in your phone under contacts and under constipation. Commonly prescribed medications, what they're for, and how much to give. You also want to ask them to increase their water. How much water should a person be taking in a day? What about increased exercise? We know that healthy people and the NIH and the CDC all recommend at least 150 minutes per week of continuous exercise. 30 minutes at a time, 10 minutes at a time, something to get the muscles moving. Remember that the GI tract is a fibromuscular hollow tube connecting the mouth to the anus. It is muscular. So when we exercise, it exercises. Increase fiber, and then let's consider if the person has opioid-induced constipation, they may need something more than a stimulant. They may need a drug such as Relistor or Amitiza that act specifically, in the case of Relistor, it's an opioid antagonist, and Amitiza actually works in the gut to change the oral channel chloride channel activators. In other words, it pulls fluid into the gut so that the stool will begin to move. This is a little grid of some of the common classes of medications used to treat constipation. Go through here and put a few of the bulking agents. List their active ingredients. And the reason you want to list the active ingredients is because when you're prescribing these, you want to make sure they're not going to interfere or react with another drug the patient is taking. What's the brand name? Now write a little prescription for yourself so that you have it and you know how it is going to be ordered. Then the ages that you're going to give for this and what the side effects are. This next section is a brief overview of diarrhea. Diarrhea is the increase in frequency, volume, or fluid content of stools. There are two types: acute, which is an abrupt onset that lasts less than a week and may be accompanied by nausea, vomiting, or fever. The most common cause is acute viral gastroenteritis. Chronic diarrhea lasts more than 2 weeks or it recurs. Keep in mind, when diarrhea occurs in an otherwise healthy patient, most likely the cause is a virus. There are different types of diarrhea. Osmotic diarrhea involves the absorption of carbohydrates. Now, we take carbohydrates into our body to use as fuel. But when the carbohydrates are not well absorbed, they're dumped into the GI tract, they can pull fluid in and cause diarrhea. Some examples of those are lactose, fructose, sorbitol, such as you see in Mentos. If a kid eats an entire sleeve of Mentos, they will likely have diarrhea. Laxative abuse is another cause of osmotic diarrhea. Celiac disease is a type of osmotic diarrhea that's caused by an immune reaction to gluten. We won't cover that in this chapter. Another type of diarrhea is secretory, acute and chronic diarrhea that is caused by toxins such as E. coli, viruses, norovirus, also by laxative abuse or endocrine tumors that stimulate the pancreatic or intestinal secretion. This overstimulates the bowel. Morphological diarrhea are changes in the mucosa of the intestinal wall from inflammation, and the classic examples of these are Crohn's disease and ulcerative colitis inflammation. These cause inflammation of the intestinal lumen, which causes diarrhea. Altered intestinal motility can be caused by things such as diabetic neuropathy, dumping syndrome, sometimes you see that after GI surgeries, irritable bowel syndrome, Parasites, antibiotic-associated diarrhea, such as Clostridium difficile. So as you can see, diarrhea has a lot of different causes. Constipation. Get the patient's definition of diarrhea. What do they think diarrhea is? Get the frequency of the BMs. Is this different from it usually is? The amount and fluidity. How much are you excreting at one time? Is it watery? What are the characteristics and the color of the stools? Are they bloody, tarry, black? Are they fatty? Is there a lot of mucus? This will give you an idea of the source or the cause. Accompanying factors. Is there nausea or vomiting? Fever, headache, myalgias or muscle aches and weaknesses? What is their dietary history? Do they have an intolerance to lactose or gluten or allergies? Have they been a recent traveler outside of the United States where they may have been exposed to contaminated food? What about drinking water? Is their water source the city water or is it a well? What medications is the person taking? There are a number of medications that can cause diarrhea. Get a good med-surg history. Is there a history of diabetes mellitus, thyroid disease, HIV, transplant, or GI surgery? You've got to ask about sexual practices as well, the number of partners, and if there's anal intercourse. Ask about social history, their living conditions. Do they live in poverty? Do they live in squalor? Family history, very important. Is there a history of colon cancer, irritable bowel disease, inflammatory bowel disease, or celiac, or any of the other GI type diseases? And then review the diagnostic reasoning algorithm that is provided in your text. It's really very thorough. Not something that you would commit to memory, but something that you want to put your hands on when you have somebody presents with diarrhea. Your textbook provides an excellent diagnostic reasoning algorithm for diarrhea, and I encourage you to mark that so that you can go to it quickly if you need to look something up. There are very few diagnostics for diarrhea, and viral gastroenteritis is covered in the next chapter. So we're going to just look at the treatment. Most treatment is supportive. Fluids such as Gatorade and Pedialyte, stopping the medication or substance that produced the diarrhea. Loperamide or Pepto-Bismol to slow down the bowel and to give the person a rest. And if you suspect that the person has Clostridium difficile or C. diff, they're going to require a referral to GI for antibiotics if you are not able to provide that for them in your clinic. Protozoal infections also require antibiotics, and those are going to require some stool samples as well. The next section is a brief overview of dyspepsia and heartburn. Heartburn is pain and burning in the retrosternal area. That's the breastbone, and sometimes it's hard to distinguish from the pain of an MI. The advent of over-the-counter H2 receptor blockers and proton pump inhibitors have decreased the frequency of dyspepsia and heartburn as a chief complaint in primary care. But it's fairly common in the general population. The most common cause is GERD. Heartburn is common in pregnant women. Dyspepsia, the symptoms include epigastric, that's upper abdominal discomfort, fullness after eating, or also called postprandial fullness, early satiety, being full with just a few bites of food, anorexia, belching, nausea, heartburn, vomiting, and bloating. The cause of dyspepsia is functional or organic. Functional, remember, means how the body works. Organic means that maybe there's a disease process. So some of the causes include alcohol intake, salicylates, that includes aspirin, NSAIDs, corticosteroids. Organic would be, for instance, Helicobacter or H. pylori. Get a thorough history, including the medications, the past medical and surgical history, social and family histories. These can be very helpful. Do a good focused exam of the abdomen and include the heart and the lungs always. Look over the diagnostic reasoning algorithm for heartburn and dyspepsia for diagnostics and differentials. This section is a brief overview of jaundice. Jaundice or icterus is the yellowing of skin, mucous membranes, and sclera caused by an increase in bilirubin in the blood. Bilirubin is a component of bile. It's what gives urine its yellow color and stool its brown color. A little bit of physiology here is important. Bilirubin comes from the breakdown of red blood cells at the end of their lives. Macrophages within the spleen and the liver break down the red blood cells into the globin and the heme molecules. The heme is then converted into iron and protoporphyrin. Protoporphyrin is converted to unconjugated bilirubin, or UCB, which is not soluble in water. This unconjugated bilirubin needs albumin to carry it to the liver, where it is then converted into conjugated bilirubin, water-soluble bilirubin. The conjugated bilirubin is sent through the bile system and stored with bile in the gallbladder. As the conjugated bilirubin is excreted from the gallbladder into the duodenum, and then it is able to give feces and urine its color. If the liver cannot conjugate bilirubin, you can have increased levels of it in the blood. The earliest sign is scleral icterus, and that's because the scleral tissue takes on the bilirubin quickly. Increased bilirubin comes from increased production, a decreased uptake of the bilirubin by the liver, decreased conjugation of the bilirubin, and decreased excretion of the bilirubin. If you look at each one of those and you think about the organ that is responsible for taking care of the bilirubin, you see that the liver is largely responsible for it. Now, the normal serum levels for bilirubin are between 0.3 and 1.0 milligrams per deciliter. You're not going to see icterus until the serum bili is greater than 2.5 to about 3.0 milligrams per deciliter. The most common causes of jaundice are gallbladder disease, cholestasis from impaired bile formation or flow. Other causes, stone in the common bile duct, that's common, liver abnormalities such as cirrhosis or viral hepatitis. Get a good history. Find out what accompanying symptoms are with this jaundice skin. Is there weight loss? Is there itching? Is there anorexia, nausea, vomiting, fever? Are there light-colored stools? Is there fatigue? All of these are going to give you clues to what is causing this jaundice. Include in there alcohol, sexual practices, and IV drug use, as sometimes cirrhosis of the liver, hepatitis that comes from unprotected sex or IV drug use can be the cause. Ask about the stool color. A stool that's light in color may be indicative of cholecystasis, cholelithiasis, cirrhosis, or another biliary obstruction. And finally, ask about anemias in the family. There are specific anemias that can cause jaundice, such as polycythemia. Do a good physical examination, beginning with inspection of the abdomen for distension. Palpate the right upper quadrant for pain and also for the liver size. Diagnostics for working up jaundice include bilirubin, the AST, ALT, and alkaline phosphatase. The alkaline phosphatase is useful in assessing for cholestasis, other gallbladder issues. The AST and the ALT are good indicators of hepatocyte damage or damage to the liver tissues. The next section is a brief overview of melena. Melanic stools are black, tarry, and positive for occult blood. Upper GI bleeding, such as ulcers, are the most common cause. Get a good history, especially for any prior ulcer diseases. Ask about medications such as iron and bismuth. The stool may be black, but it may not be positive for occult blood. Person may be taking iron or bismuth. Bismuth is the active ingredient in Pepto-Bismol. A melanic stool takes about 100 to 200 milliliters of blood to create it. This melena can continue for several days after the acute bleeding has stopped. Think about the difference between the upper GI and the rectum and anus, where the stool comes from. So if there is a bleed for a few days and then it stops, it takes several days for all of that stool to evacuate the bowel. Signs and symptoms associated with GI bleed depend on the source, the rate of the bleeding, and any comorbid diseases. If someone is bleeding profusely, then they are probably going to have more than melanic stools. If they have comorbid diseases such as diverticular disease, their stools may be more bloody than they are tarry and black because that source is closer to the rectum and the anus. Diagnostics include complete blood count. You're going to check for anemia, and endoscopy is helpful for upper GIs. Management depends on cause. The next section is an overview of nausea and vomiting. Nausea and vomiting can be caused by many disorders. Vomiting is that forceful expulsion of gastric contents. Nausea is that unpleasant sensation in the stomach that is accompanied by symptoms such as increased salivation, sweating, decreased blood pressure. The most common cause of nausea and vomiting is gastroenteritis. There are other causes to think about. Central nervous system disorders, I think of migraines. Other disorders such as motion sickness. Medications can cause nausea and vomiting. Digitalis, estrogen, opiates, and of course pregnancy causes nausea and vomiting. In getting the history, ask about the characteristics of the vomitus. How much is there? What is it made of? Is it mostly solid foods? Is it bile? Is there a smell to it? Or is there no smell to it? What are the associated symptoms? Things such as hearing loss and vertigo can help you figure out Meniere's disease, diarrhea, gastroenteritis, abdominal pain. So asking about the associated symptoms is very helpful. Management is typically symptomatic. The common drugs that are prescribed are listed in Chapter 38, and these include antihistamines and serotonin receptor antagonists such as Zofran. This last section is on dysphagia. Dysphagia means difficulty swallowing that either has or doesn't have painful swallowing with it. You can have dysphagia or difficulty swallowing without it being painful. Causes include mechanical obstructions and functional problems. Mechanical obstruction usually has to do with the structures of the mouth, the throat, the esophagus, while functional problems tend to be neurologic or muscular. So think of Parkinson's or muscular sclerosis or ALS. Other problems can include psychological, such as acute anxiety or panic. These impair motility. That means the movement of the food from the mouth to the stomach. Diagnostics that are helpful are endoscopy. It's the first choice to evaluate chronic dysphagia. And fluoroscopic swallow studies are also helpful, as the therapist can actually watch the transit of food from the mouth into the stomach and be able to identify any kind of a structural problem.